Can you guys see it?
Looks great.
Okay, good. So Chad's gonna start us off.
All right, so welcome to the Overdose Education and Prevention Training. I assume everybody in here is kind of familiar with Narcan's and Naloxone and that whole wheelhouse. Is anybody in here unfamiliar with Naloxone? Okay. I can't see anybody's hand, so unless you come off of mute, then I'm not going to be able to see anything. And if anybody has any questions at any point, please feel free to come off of mute and yeah, feel free to ask. So we're going to be going over our session objectives. We acknowledge that by now many people have more awareness about this public health emergency. There's a lot of information out there that can inform our efforts to reduce overdose, but the volume of information can be overwhelming. Our website contains links to fact sheets that provide references to the sources of information cited in this session. In this session, we're going to address four basic aims. First, we're going to review the data can tell us about the current overdose mortality. Then we're going to introduce a framework for understanding the many factors that drive overdose incidence and death, including current trends in the drug supply to continue to monitor. Next, we will review possible actions that we all take to help prevent overdoses from occurring in the first place. Then we're going to review the critical steps you can personally take to reverse an overdose and save a life. Overdose mortality in the US and Texas. So in this graph here, it shows the three waves that the opioid epidemic occurred in, with the smallest piece of the pie really being when we started tracking all this information, and the biggest one being where we're at. I don't know if it's completely up to date. I believe it's 2018, if I remember correctly, is when we got this graph, but it really demonstrates how bad opioids have gotten, especially synthetics. So, like I said, the three waves of the opioid epidemic is what we're going to be talking about. The first wave began with the overprescribing of painkillers in the late 90s. While more pharmaceutical opioids crept into the illicit market, people mostly knew what they were getting and they weren't unexpectedly lethal. And the second wave began in 2010, and increased regulation and decreased prescribing of opioid painkillers did not reduce the demand. And as many opioid dependent people turn to illicit opioids, such as heroin, which are generally less expensive and easier to obtain, but of course unregulated and unpredictable. The third wave then began in 2013 with a significant increase in overdose deaths involving high-potency synthetic opioids, particularly those containing illicitly manufactured fentanyl. The market continues to change, and fentanyl now dominates the street market. It can now be found in combination with heroin, counterfeit pills, and stimulants such as cocaine and methamphetamine. This next graph kind of shows it's another way to show the climb in overdose deaths. And as you can see in this data, overdose deaths excluding methadone have increased 50-fold. And overdose deaths involving prescription opioids did increase 4-fold, but are on the decline. Overdose deaths involving psychostimulants, primarily methamphetamine, have increased 30-fold. But many of those did also involve opioids. Non-opioid involved stimulant overdoses are very different from those that do involve opioids, as there is no medication equivalent to naloxone for stimulants. And research indicates that death from acute stimulant toxicity is often an outcome of long-term cumulative exposure, leading to cardiovascular dysfunction or a heart attack. And now I'm going to be passing it over to my co-trainer, Javi. Thank you.
Hello, everybody. Hope you're having a good day. Let's go over to a number of accidental overdose deaths by opioid. In this chart, we will see that the profound impact of synthetic opioids is no different. So, so here we are experiencing roughly. Let's get that out of the way. And so here we're experiencing roughly 300 deaths per day across the U.S. More than 12 people per hour, one person, a mom, a dad, a son, daughter, dying every 5 minutes. At this point, we are roughly 5,000 people are dying from overdose in Texas every 12 months. Reducing risks. The history of U.S. drug problems and associated policies and responses in replete within oversimplifications of these complex issues. So how might we unpack all this complexity to inform our response? Ultimately, to truly understand overdose risk and response, we must be able to address the interplay of chemical, physical, psychological, social, and cultural perimeters that shape substance use and misuse. Our aim today is to provide a framework to help us each continue to clarify our thinking about the many individual and social factors that shape drug use, misuse, and associated risks of overdose in order to help prevent them from occurring in the first place. Over 30 years ago, Dr. Norman Zinberg at Yale University observed that most of his patients who use illicit drugs actually do not suffer from fatal or very negative consequences. So he was interested to understand not only risks, but protective factors. He developed a three-part framework called drug, set, and setting. The model acknowledges that, yes, of course, the drug itself is important, but not only the important variable. Then the model acknowledges the great variation in what people bring to their drug use. Zimberg referred to this as set, which can be short for mindset. That includes their expectations, emotional and mental wellness, accuracy of their knowledge about drugs and their effect, and each person's unique physiology. Finally, Zimberg observed the considerable influence of setting like the drugs themselves and the expectations folks bring to their many environmental factors operate to enable their effects and each person's unique physiology. Finally, Zimberg observed the considerable influence of the setting, like the drugs themselves, and the expectations folks bring to their use. Many environmental factors operate to enable or constrain the safety of the drug use. Let's dive deeper into each domain. Of course, the chemical properties of the drugs are important to thoroughly understand. Accurate potency, effects, and half-life of drugs are important to understand not only the people who work in the field, but even more so for people who use drugs. Building on that understanding, the combined and synergistic effects of using more than one drug substance is necessary. And lastly, the method used when taking substances can significantly influence the effects. Fentanyl synthetics. We noted that fentanyl is now directly involved in the majority of overdose deaths across the country. Fentanyl is a synthetic opioid approved by the Food and Drug Administration for use as an analgesic, pain relief, and anesthetic. This drug was intended to be used for cancer pain or short-term use during major medical procedures. Medically, it is often formulated in a patch to be applied to the skin for very slow release and effects. Taken otherwise, yes, fentanyl is potent. Fentanyl can be 50 to 100 times more potent than heroin or morphine as an analgesic. Most of the fentanyl that we are experiencing on the streets around the country and in Texas is illicitly manufactured. Fentanyl presence is in the illicit drug market as exploded for several reasons. The formulation is easier to manufacture in a laboratory compared to harvesting poppy and producing heroin. And because of its potency, it is much easier to transport many more doses per pound, which greatly reduces the risk for drug traffickers. Fentanyl has functionally displaced heroin as the primary street opioid, and in many parts of the country. The trend that will only continue and has been taking place in Texas. It is hard to understate how much fentanyl has altered the dynamics of vulnerability and overdose risk. Indeed, driving rapid increase in overdose deaths across the country. In some U.S. cities, fentanyl is in some U.S. cities, fentanyl has, in practical terms, displaced heroin and essentially the only available opioid on the street. There is inherent risk in the using fentanyl when one knows that this is the substance they are taking, although having the formulation of absolute helpful in reducing those risks. Even more problematic has been the cross-contamination of a variety of street drugs with fentanyl, such that people may be unaware that they are introducing their body. Of course, the degree in which any drug on the street may be cut with fentanyl is unpredictable. Fentanyl involvement in heroin, stimulant, and prescription pill deaths has grown substantially. Research is now also finding evidence confirming that a significant proportion of fentanyl overdose descendants may have not intended to consume an opioid on the occasion of their death. Polypharmacy. The fact that most people who experience an overdose and have more than one, if not multiple substances in their system is not new. Being informed, able to talk with folks about the relevance of polypharmacy is critical, especially, of course, as some of these substances are legal and may even be more prescribed, such as alcohol and other sedatives, like benzodiazepines. People express many different reasons for taking multiple substances, such as enhancing the effect, additive, and synergistic reward of compensating the undesired effects of one drug by taking another, and many more. That synergistic effect can be the difference between life and death. While some given beliefs may not be quite accurate, the consequences certainly are, and providing accurate information must be our focus. I'm going to pass it over to Chad. Thank you.
So going off of polypharmacy, we're going to talk a little bit about xylazine and how that kind of plays its role in the environment today. So xylazine is a non-opioid medication used as a sedative and muscle relaxant in veterinary medicine, or an animal tranquilizer. Xylazine is not currently on the list of controlled substances under the Federal Controlled Substances Act. Although not approved for use in humans, xylazine is increasingly added to street drugs and is often found in combination with fentanyl. Xylazine is used to extend the high from opioids. So some people may also be ingesting xylazine unintentionally when it's cut with other drugs. People who regularly use xylazine often have severe skin ulcers and abscesses which spread and worsen quickly and do not heal on their own, requiring medical attention. Extended periods of drowsiness or disorientation after drug use can be signs of xylazine use. Xylazine is not an opioid, and naloxone will not reverse its effects. However, opioids like fentanyl are almost always present with xylazine in drug samples, so it's still recommended to use naloxone when responding to an overdose. Since the main effect of xylazine is heavy and prolonged sedation, the person who is overdosed will likely still be unresponsive. When xylazine is found in combination with fentanyl, the signs and symptoms can include blue/grayish skin and slowed breathing and heart rate. There is no rapid test for xylazine. One of the downstream effects of wounds is that people cannot get into inpatient rehabilitation programs or recovery houses, as many of them do not accept complex medical cases. Xylazine has been reported in Texas poison centers for over 10 years now. It is increasingly showing up in toxicology reports for both fatal and non-fatal overdoses. Following that, we're going to talk about SET. Zimberg called this short for mindset, and generally understood as the expectations with varying degrees of consciousness that a person brings to the experience. That is, people use drugs for a whole host of different reasons, which may change over time. Whether seeking to fit in or escape or explore or pursue a spiritual experience or comply with medical advice or especially address physical and or emotional pain, none of these motivations are right or wrong. Of course, in the case of opioid dependence, folks are primarily using opioids to stave off withdrawal symptoms, which are extremely unpleasant. Gaining insights into those expectations, however, can be helpful. We can organize the concept of SET into 3 buckets. First, mental health. The US was experiencing a mental health crisis well before COVID, and as we've seen, it has only been made worse. Rates of depression and anxiety and other challenges have steadily increased, while access to services and supports have been constrained, which has no doubt led to increases in self-medication. We have seen these effects exacerbated through COVID-19 pandemic with significant increases in stress, anxiety, and unprecedented degrees of isolation. Since 2020, all 50 states have reported increases in opioid-related mortality. Unaddressed trauma is at the core of substance misuse and disorders for many people, and often as well multiple experiences of abuse. Increasing access to evidence-based mental health treatment and care is imperative. Relatedly, study after study shows the effects of stigma and discrimination directly on the well-being of people using drugs, as well as harm reduction programs seeking to serve them, ultimately diminishing access to life-saving services and naloxone. Folks experiencing stigma and discrimination are more likely to use alone, skip safety steps, and less likely to be able to access services and supports. We must build strong connections and support systems, battle misinformation with accurate information, and pay attention to the terminology we use, i.e., using people-first language. The physiological factors that one brings to their drug use is also quite relevant. There is a wide variation among folks' tolerance and the underlying health status and conditions one may be experiencing can create significantly increased risk, especially diseases of the lungs or heart. We should also mention chronic pain. Just as the liberalization of pain treatment and increased prescribing of opioids helped to fuel the epidemic beginning a couple of decades ago, the widespread reductions in prescribing of all 50 states in the last few years has served as an overcorrection, i.e. the first and second wave, and left many people living with chronic pain without access to evidence-based treatment, also driving people back to the illicit market for pain relief. And again, accurate knowledge. We must especially support each other with reliable and accurate information about drugs, their inherent risks and benefits, and measures that we can all take to increase safety. Lack of access to reliable information kills. Even then, while knowledge is necessary, it is not sufficient. As many of the as many of the countries and the world's most knowledgeable experts on overdose risk and prevention have in themselves indeed died from an overdose, emphasizing the importance of social connectivity in the setting in which people use. Do not use alone. Just as much as the drugs themselves matter, as well as what each individual brings to their drug use, the setting itself is shaped by multiple factors that increase or decrease one's potential risk for overdose. This is sometimes referred to as the risk environment. Certainly is the setting, and the setting is the practice of using alone. Stated simply, if one experiences an overdose and there is nobody there to assist them, a fatality is a lot more likely. People use alone for a lot of different reasons, often keeping their use private for fear of negative consequences, such as losing their housing or job or custody of their children. We also know that while people may build very high levels of tolerance to opioids over time, those same people who return to use after periods of abstinence may accidentally overdose after that tolerance is greatly diminished. This is especially the case for folks who may be coming out of periods of incarceration or residential treatment or recovery centers. We want to be mindful that the change in the risk environment when folks move from one setting to another. And that's why we hand out Naloxone to our opioid users who are leaving the centers. In those and all settings, it is especially important for people to have access to the materials and information and support that can help to keep them safe. Obviously, in the case of opioid overdose, the availability of naloxone in any given setting is critical. The extent of naloxone distribution and accessibility is key. In addition to traditional first responders like firemen and police, as well as pharmacy-based access, it is especially important to expand naloxone access through community-based programs, which have been especially successful in reaching the most vulnerable members of our society. Such multi-pronged efforts are needed to achieve what is known as the concept of saturation, which is basically to ensure that the people in any given community who are most likely to witness and respond to an overdose have naloxone readily available. Unfortunately, when it comes to the overdose epidemic in the US, the many decades of barriers that folks have experienced in accessing treatment, care, and support associated with drug use and misuse, stigma and discrimination are as profound as ever. And I'm going to send it back to Javi. Thank you.
All right, let's get into mood axis. We have known for a long time that medications for opioid use disorder are linked to reduced risk of death in opioid use disorder. Studies show that only 20% of people who may benefit from mood are able to access those services. Harm reduction practices that increase access to vital materials, information, and support to keep people safe while they are actively using also greatly increase the likelihood that someone who is interested to access evidence-based treatment will get connected. Review, drug set and setting. So, for a quick review, for locating harm, yes, of course, the drugs matter. Fentanyl has been a game changer. Its spread of uniquity in the illicit drug market and the cross-contamination of other drugs with fentanyl, issues of unknown quality and purity. How the drugs are administered, all of these factors have changed the game and public health challenges we face. Does that matter? Yes, indeed. Everyone brings their own expectations and motivations to their drug use. In the case of opioids, we know that they are very effective. Fentanyl is especially good at treating pain, whether it is physical or emotional pain, whether it is not, it is associated with the pain of withdrawal symptoms. Polysubstance use and associated challenges continue to increase. We also know that physiological factors can increase the risk of overdose, and that includes decreased tolerance as well as conditions like lung and heart disease. Accurate knowledge is critical to safer use. And again, the setting, people, places, the things that the people with whom folks are using or not, the setting in which they are using, and the materials, information, and support that they may or not be able to them all matter. Whether we know beyond a doubt that using alone is perhaps the number one risk factor for mortality in the event of an overdose. Chief among those materials in the case of opioid overdose in naloxone and a person who knows how to administer it. When we are done, we encourage you to reflect upon the drug, set and setting, framework, and think about your observations, experiences, and possible gaps in your knowledge and experience awareness that you might like to fill. Taking action. Yes, despite all of our accumulated evidence and experience, overdose deaths continue to climb. What can we be doing better to prevent overdoses from occurring in the first place? Harm reduction. More than anything, we always want to keep folks alive and give people a chance at recovery. Whatever we can do to reduce the harmful consequences of drug use and supporting any positive change is critical to increasing the opportunities and likelihood for folks to meet their self-directed goals and improve their health and well-being. Applying principle of harm reduction is not controversial, but rather quite common and evidence-based. At its core, harm reduction is a set of principles that we apply every day in all types of situations. For people using drugs, meeting where they are at, offering materials, accurate information, and support regarding actions that they may take to keep themselves and their peers safer, not only reduces harm and sometimes very expensive consequences, but also builds trust and self-efficiency. It is helpful to think of harm reduction as compassionate pragmatism. We take this approach with all types of chronic disease and conditions. Substance use disorders and associated conditions are no different. Actions to take. We all come to this effort and from a different lived experience. Reflect on what you bring to our shared efforts. Think about what you might do in the terms of sharing information, materials, connection, and support to prevent an overdose of your friend, family or member or neighbor. And remember, harm reduction treatment and recovery support services are all mutually reinforcing and creating the multiple pathways that are needed to build on our collective strengths, enhance safety, reduce an overdose, and deliver hope. Passing it over to my friend Chad.
Thank you, Javi. And now the easiest part of our session and the quickest, we are going to review the simple steps we can take to each administer naloxone and save a life. First, we're going to talk about some basics on the physiology of an opioid overdose, then some background on the opioid antidote naloxone, then followed by recognizing opioid overdoses. Thank you, brother. By opioid overdoses, we are also going to quickly review the topic of stimulant overdose, important distinctions with opioids, and considerations in response. I don't believe it actually does touch on stimulant overdoses. I might be wrong, but the main difference is stimulant overdose is really just heart failure, and there's no medication for that. That's just EMS. So as we know, one can experience overdose of many substances, including alcohol, benzos, aspirins, or other drugs. But we are talking about opioids, far and away the most lethal. Opioid overdoses occur when there are too many opioids or a combination of opioids and other drugs in the body. They cause respiratory arrest, or in other words, people stop breathing and are not responsive to stimulation. In this graphic, you can see how opioids fit perfectly on what are known as the mu receptors in the brain. When this happens, opioids are really effective at relieving pain. It can cause a sense of euphoria. But if the opioid dose is too high, they can also interfere with the brain's respiratory center, causing inadequate respirations or complete respiratory failure. When someone cannot breathe or is not breathing enough, the oxygen levels in the blood decrease and the lips and fingers turn blue. This is called cyanosis. This oxygen starvation eventually stops other vital organs like the heart, then the brain. This leads to unconsciousness, coma, and then death. In this graphic, we show how naloxone works, and this is because naloxone has a higher affinity for the opioid receptors than opioids. As well as opioids work in a battle for the mu receptors, naloxone always beats opioids. This is the only effect that naloxone has. It doesn't pose any risk, and it only works on opioids. It's important to keep in mind, though, that the effects of naloxone only last 30 to 90 minutes. That's why it's important for an individual who has experienced an overdose that was reversed with naloxone to seek immediate medical attention following. This is because many forms of opioids have a longer effect than only 30 to 90 minutes, and that individual, once the Narcan or the naloxone wears off, might go back into respiratory failure and experience an overdose again. Within 3 to 5 minutes without oxygen, brain damage starts to occur, soon followed by death. With opioid overdoses, surviving or dying wholly depends upon breathing and oxygen. Fortunately, this process is rarely instantaneous. People slowly stop breathing, which usually happens minutes to hours after the drug was used. While people have been found dead with a needle in their arm, more often than not, there is time to intervene between the time when an overdose starts and when a victim dies. We're going to talk a little bit about naloxone and how it came to be about. Naloxone is not a new medication. It was invented in 1961 and patented in the US in 1966. Then in 1971, the FDA approved naloxone for treatment of opioid overdose by intravenous or intramuscular injection. Naloxone is on the World Health Organization's list of essential medications. As demand increased, community-based programs started expanding distribution in the early 2000s. Community-based programs, primarily syringe service programs, began distributing injectable naloxone, resulting in a significant number of overdose reversals among drug users. This demonstrated that non-traditional first responders, i.e., people such as friends and family members of drug users, were more than capable of administering naloxone and saving lives. In 2008, new formulations were being developed like atomizers that helped people administer naloxone intranasally with pre-filled syringes but without needles. Eventually, in 2015, the intranasal formulation known as Narcan was FDA approved. Each order of Narcan nasal spray will include a box with 2 doses. This is important since it's always recommended you carry 2 doses of naloxone just in case one is not enough. You might need to re-administer, and we recommend you do that 2 to 3 minutes after the first administration. You're going to want to protect it as much as possible from extreme temperatures, 40 to 80 degrees being ideal. Leaving it in a car in the hot Texas summer is not a good idea, as the heat doesn't necessarily affect the potency of naloxone. More so, it can just evaporate. So keeping it below 80 degrees is ideal for keeping the whole dose in the Narcan. Also, I did want to touch on, and this is something that I learned once I started working here, is that Narcan is the brand name, naloxone is the drug. So naloxone is really that's just something I want to touch on. Thought it was interesting. It can be challenging to tell if a person is just very high. Sorry, I got a little bit ahead of myself. Step 1 in evaluating for an overdose. It can be challenging to tell if a person is just very high or experiencing an overdose. If you're having a hard time telling the difference, it is best to treat the situation like an overdose. It could save someone's life if someone is really high and using downers like heroin or pills. Their pupils will contract and appear small. Their muscles are slack and droopy. They might nod out. They might scratch a lot due to itchy skin, and their speech might be slurred. They might be out of it, but if they respond to outside stimuli like loud noises or a light shake from a concerned friend, they are not yet necessarily experiencing an overdose. If you are worried that somebody's getting too high, it is important that you don't leave them alone. If the person is still conscious, walk them around, keep them awake, and monitor their breathing. There are symptoms that we need to be aware of to help identify individuals who are overdosing. I'm gonna pass that over to Javi.
All right. Recognize an overdose. As overdose continues, the individual become unresponsive. So efforts to try take, awaken, or shake them will not work. They will have shallow breathing, which may include a gurgling sound. Their skin will be noticeably pale or blue, particularly their lips and nails. This is because there is less oxygen circulating in their bloodstream. Their pulse may also be weak or absent. Finally, a fatal overdose occurs when breathing stops completely and there is no pulse. Recognizing overdose. Call the person's name and tap the person's shoulder. If no response, try pinching the earlobe or fingertips. If this doesn't work, forcefully grind knuckles into their sternum for 10 seconds. If the person responds, assess whether or he or she can maintain responsiveness and breathing. Continue to monitor the person, including breathing and alertness, and try to keep the person awake and alert. If none of this works, call 911. You do not have to report an overdose. You can say, my friend is unconscious and is not breathing. Give your location, don't leave. Don't try ineffective strategies. Unfortunately, one of the issues in providing assistance is the fear that witnesses may be arrested. If they call 911, as a result, witnesses may leave or abandon the individual instead of rendering aid. This is the worst possible response to an overdose and may contribute to death. Even though naloxone can fix the overdose, there may be other health problems going on. Also, people who survive any type of overdose are at risk of experiencing other health complications. As a result of the OD, such a pneumonia or heart problems, getting someone to be checked out or by a medical professional is an important part of reducing the harms associated with an overdose. Why we can do this in Texas? Again, you are protected by the intervene and able to carry and administer Narcan in Texas without a prescription. There is a statewide standing order that went into effect following the passing of Texas State Bill 1462 in 2015. The legislation says that Texans who carry and administer Narcan in good faith and in an attempt to save a life are protected from criminal and civil liability, as well as professional disciplinary action for those who are licensed healthcare providers. Here's how. Gently place the person on their back if possible. Passing over to Marisela.
Okay, now we're gonna get into how you actually use the naloxone. And Chad is giving a demonstration. So now we're gonna get into how to use naloxone. And this is the most important step. Grab your naloxone, open the box, take out one of the two nose sprays and peel it open. Insert it into the person's nostril until your fingers touch the edges of their nostril. Once you've done that, press the plunger and release the entire dose. And he actually just Narcaned himself. Remember, the nasal mucus is very vascular and will readily absorb the Narcan. The person doesn't have to be breathing for the Narcan to work. And if you don't have opioids in your system, nothing happens. Chad is okay. Now we're going to get into intramuscular naloxone. So for this, you would use a long needle, 1 to 1.5 inches long, and it comes with the intramuscular naloxone. This is called the IM intramuscular needle, usually 22 to 25 gauge long. You would pop off the orange top vial in the syringe. You would draw up 1 cc of naloxone into the syringe. 1 cc equals 1 milliliter. You would inject into a muscle, like the front of the thigh, upper outer quadrant of the butt, or the muscle in the shoulder, like a flu shot. And you would inject it straight in to make sure, you got to make sure to hit the muscle. Rescue breathing. So here at the office, a few of us just got, we are CPR certified now. It's very important when you're dealing with overdoses and naloxone. So if you are able and willing, provide rescue breathing after administering naloxone. Here's how. Gently place the person on their back and lift their chin to clear their airway and make breathing easier. You get the person on their back, tip their head back to straighten the airway. One hand on the jaw and one on the forehead. Pinch their nostrils shut. Put your mouth over theirs, form a seal, and do 2 short breaths. If the chest rises, you are good. If the belly rises, readjust. If nothing rises, check for blockages. Then, 1 breath every 5 seconds. If after 3 minutes you are seeing no change, administer another dose. And 3 minutes feels like an eternity. Returning to our discussion about the increased presence of xylazine in the illicit drug market, this can complicate or confuse overdose reversals. Xylazine is a powerful sedative, so folks may remain unresponsive even after their breathing resumes. Remember, always administer naloxone, as it is very unlikely that opioids will not be present if someone is exposed to xylazine. If breathing returns, but the person is not awake, they should be placed on their side in the recovery position. And as always, stay with the person. It may take a long time for them to regain consciousness, and depending on the unknown amount of opioids in their system, they may need another dose of naloxone. What is the recovery position? First, roll the person on their side while waiting 2 to 3 minutes for the naloxone to take effect. You bend their knee, you turn their face to the side. This will help to keep their airway clear and prevent them from choking on their vomit if they begin to throw up. If you're trained in basic life support and feel comfortable doing it, you can also provide rescue breathing for the person while you wait. Keep in mind, when they wake up, they may be very disoriented and frightened. If 3 minutes pass and the person still hasn't woken up, you can deliver another dose of naloxone and continue rescue breathing. In rare circumstances, it may be necessary to deliver a 3rd dose if the person still has not awakened, 3 to 4 minutes after the 2nd dose. But hopefully by that time, help will have arrived. Step 5, monitor response. Once the individual is conscious and EMS has been contacted, there are a few things to consider. If folks are opioid dependent, the naloxone may put them into withdrawal, which is not life-threatening, but can be very unpleasant. They may feel sick and not be happy with you. But that's okay, they're alive. Symptoms of withdrawal may include diarrhea, abdominal cramping, anxiety, agitation, goosebumps on the skin, nausea and vomiting, rapid heartbeat, and high blood pressure. Asking folks to accept medical attention will help manage withdrawal. Let the individual know what happened. Let them know that they overdosed and that you gave them naloxone. Additionally, naloxone only lasts somewhere between 30 to 90 minutes. If they took a large dose of opioids, these drugs may outlast the effects, making them susceptible to more respiratory depression. So be vigilant. So if they took a large amount of opioids and it's been past 90 minutes, they could go back into an overdose. So it's recommended for them, for everybody to call EMS, whoever's going through the overdose or is there present. So it's 5 steps. That's all it takes. You assess and recognize if you are witnessing an overdose. If yes, call 911. Respond with naloxone. Place the person in the recovery position. Monitor their breathing and overall response. And take further action if necessary.
Can you bring up slide 28?
Okay, and I'm gonna bring up slide 28.
Okay, so as a part of our review, I wanted to touch a little more on slide 28. So here it says call 911, and it says you don't have to report an overdose. You can say my friend is unconscious and not breathing. And the reason why we've heard that you say that is because the second they suspect that there are drugs involved, they're gonna send PD. Now, personally, I'm not too aware. Like, let's say we're in the Northeast, right? And you say my friend is unconscious and not breathing. I don't know how that works. This area is pretty notorious for drug use and overdose. So I don't know for sure if they would still send PD or not. But we have been told that you can just say that my friend is unconscious and not breathing, and they will only send EMS. So I did want to highlight that as part of the review. Other than that, thank you, Maricela. I'm going to pass it back to you. Sorry.
So that was our training. Does anybody have any questions? Okay, well, thank